Hello and welcome to the Birth Untethered podcast. I'm Shellie, a long-time doula, advocate and former university lecturer.
And I'm Kemi, a badass birth keeper, formerly a UK registered midwife.
Just a couple of rebels with decades of combined experience in pregnancy, birth and beyond getting together to share wisdom. We exist to equip birth workers, families and seekers of truth with informed choice, not fear. Come as you are, learn what they don't teach. This is the birth revolution and you're all invited.
Hello everybody and welcome to this episode with me, Shellie, and the lovely Kemi.
Hi,
Welcome.
my mouth's full as usual. Chewing some gummies.
she's had her brekkie. She's ready to go. She's fueled up, ready to go. And today we are diving more into that immediate postpartum. So we've kind of cycled through birth a little bit, dipped our toes in last time and cycled back. And actually I wanted to start by cycling back because when I was re-going over the episode and sorting out the subtitles and everything for those of you viewing us on Patreon, I realised that when I was talking about the kind of feedback cycle of oxytocin that's happening, that I might have said it in a slightly confusing way. So I just wanted to clarify that when we get the baby pushing down into the oxytocin receptors, we're getting a neurological feedback loop that's happening back going up into the brain. And it's like multifactorial. So it's affected by the parasympathetic nervous system, the sympathetic nervous system, how scared you're feeling, whether there's adrenaline release. It's also affected by the amount of waste products that are being built up in the uterus, so lactic acid by the contraction. So when you get a strong contraction and there's a big buildup of lactic acid, that's part of the feedback mechanism that slows down the oxytocin release from the brain, which gives a bit of a longer break so that the uterus and baby can recover and the placenta can reperfuse and things like that. So I just wanted to be clear that that's how that kind of cycle works in a physiological birth. Now, obviously, if we're having an induced or augmented labour with synthetic oxytocin, that feedback mechanism is blocked. If we've got an epidural in the way, that feedback mechanism is somewhat blocked. So then what's happening is that they are titrating synthetic oxytocin in. So rather than it coming in pulses from the brain into the body, you're getting this continuous stream into the bloodstream. So you're not getting the increase in endorphins, the natural increase in endorphins and brain release of oxytocin. We're just getting this steady kind of state in the bloodstream, which can mean that the uterus is contracting more than is safe and, okay for your uterus and for your baby. So you are more likely to get more lactic acid buildup. It's more likely to be more painful because you're not getting the rest period in between that maybe your body and baby need. So that's one of the reasons why it's more painful. And you get this oversaturation of the uterus. So we touched on this a little bit last time. So the baby's more likely to get distressed. And actually some effects were highlighted by a meta-analysis systematic review in March this year, 2025, that demonstrated that if you do not have synthetic oxytocin in your labour, you get a 20% reduction in the likelihood of cesarean. You get a 55% lower likelihood of uterine tachysystole, which is where the uterus is contracting way too quickly. And you get a 36% reduction in non-reassuring fetal heart rates. So that's where the baby's looking like they're not really coping with the labour. In this study, they showed actually that with the use of synthetic oxytocin, on average, it only shortened the labour by 30 minutes overall, over the whole of the length of the labour, and that it only shortened the pushing phase of labour by 6 minutes.
Wow.
So that's just something for you to think, are all these interventions, are all these risks worth a 30-minute difference, or are they not? So I leave that decision up to you. And obviously we know with that synthetic oxytocin, it increases the hemorrhage risk. And we spoke a bit about that last time, just at the end of the podcast, we kind of touched on it. Postpartum hemorrhage is a negligence issue following mismanagement by healthcare providers in the third stage of labour. In instances where there is poor service delivery, women can receive poor maternal care that exposes them to complications. So the most common cause of postpartum hemorrhage is going to be uterine atony. So that's where the uterus becomes floppy, it becomes boggy, it's not able to contract and clamp down where the placenta is attached and close off those exposed blood vessels. But it's can be really by four reasons. So one is trauma, injuries resulting from laceration. So if you're having an episiotomy, they're using forceps, there's things coming, or sometimes from the baby, especially if the baby's coming in an awkward position with their hand by the head or something like that. The tone, as we said there, that tone of the uterus. Thrombin, so if there are any bleeding disorders, clotting disorders. And the last one is tissue. So if there is retained tissue inside the uterus, so maybe a part of the placenta, maybe an extra lobe of placenta. It's incredibly rare. I think it's about 1 in 10,000 births or something like that happens. And these things are more common. That tissue being left behind is more common in a managed birth because they will be pulling on your placenta, so they can tear the placenta, or they can pull if the placenta is not ready and they're pulling too firmly. It can actually cause bleeding to increase. It can even cause the uterus actually to be pulled out of the body. So basically, the less you interfere and fiddle, the better. And it's really clear that all of the fiddling is making things worse, because the hypermedicalization of normal birth process in this study said may explain the increasing incidence of postpartum hemorrhage globally, because it's in the United States, it has increased by 27% from 1995 to 2004. So that's going to be even more in recent history because the amount of induction has really increased exponentially. And then there was a recent study from 2009 to 2015 in a particular hospital in the United States. Their PPH amount increased by 47.5%.
Yeah.
And there was a paper in 2021. They stated that there has been a doubling of postpartum hemorrhage over the last few years in the United States of America. And it's all to do with that interruption, that disruption of physiology. So if we can avoid that, that would be really wonderful. Mm-hmm. And we sort of touched on it last time, but there are these amazing things happening after birth if you are left undisturbed. Mm-hmm. And it's perfectly safe to do that. So you can catch your own baby. You don't need anybody else's hands on your baby if you don't want. Your partner can catch your baby. You can do it together. It's a really lovely thing to do. You can have a midwife or someone close to you guiding you, letting you know what to expect, letting you know how to do it safely. But they can just come straight into your microbiome and your partner, your familial microbiome, and stay there without anybody else. You don't need other people vigorously rubbing your baby, doing anything. You can instinctively do that yourself. Just dry them off if you need to, or give them a little rub, give them a little talk to them. And when babies are undisturbed in that way, they go through a very predictable series of or expressions of instinctive behaviors, as do mothers. So we touched on that a little bit last time, didn't we, with the mother, where you get this kind of pause, like the wow, I did that. Sometimes you feel a bit shocked, amazed at yourself at how oh, I did it, look what I did. Often there's quite a lot of swearing. Have you found that going like, fucking hell, I did that?
Yeah.
Which is really gorgeous. I love that.
It is.
And after that pause, you can look over the baby. And as Kemi was saying, if you've got a partner with you, this connection to your partner, the look to the baby, to the partner, this is what we did, and this integration of you now as a family, on the outside. Yeah, it feels very different when the baby's on the outside to when they're on the inside. And with a baby, when they're left skin to skin, they will go through this canonical sequence of behaviours. So they may have a little cry. We talked about last time that they might have a big complaint. But in my experience with physiological birth, where babies aren't taken off or disturbed by the presence of other people doing things, they don't tend to cry very long. They'll have like
so true.
To help open the lungs, because a cry does help open the lungs. It's not essential. I mean, when Seb was born, he was chill as anything. He came out, he was just looking at me and looking at Sai, because we were very close to Sai helped bring him up to me. And he just went, like did a little stretch.
Yeah.
Just made this tiny little noise. and then kept looking at us.
Yes.
So I think that's really important to understand, because on films and things, it's always, the baby's not crying, and why is the baby not crying? And everyone's panicking that the baby's not crying. Babies don't have to cry when they're born, and actually they don't often in a physiological birth, because they've got nothing to cry about. They're not frightened. They're not being vigorously wriggled around or poked or prodded or have needles poked in them or whatever. They're just like, oh, a bit like you, this is different. Whoa. And they're just taking everything in, and they're looking at it. And then if they are on you, they will then relax after that shout, especially if you're talking to them. They will chill. They might just lie there for a bit, looking at you, looking at dad or your or the partner, recognizing the voices, hearing the voices that they've heard from the inside. And then they actually tend to start to wake up. They have this kind of awakening, and they will start making their way to the booby. Like we spoke about last time. They're going to be they crawl a little bit, rest a little bit. They might have a little, like tell you a little bit about it, and then they move a little bit more. They're making their way to that bullseye, to that gold colostrum that they're just looking forward to, because they got a bit hungry from birth. It's hard work on them. There's a lot of stress on the body when it's happening. They're using up those brown fat reserves to help fuel that process, so they're looking for some grub. They're looking for that post-birth meal, much like you probably will be thinking about it shortly afterwards.
Shortly after.
Get me some
there
food.
is a bit of time, usually between 30 and 45 minutes, they will reach the bullseye, and it doesn't need to be rushed, and they don't need to be picked up off your belly and moved to your boob or any of those things. You can just allow that development for them. It's a leap for them being born, and we don't need to rush them.
No, we want that time. You want that time for them to crawl and familiarize themselves with you, your body. That movement of them on your belly helps your uterus to shrink down. It helps that oxytocin to trigger off. The little pouring of the hands is helping the oxytocin to boost, which again is helping to prevent haemorrhage for you, helping the placenta to deliver safely. And they are familiarizing themselves. So they have this surge of catecholamines before birth, as well as that surge of oxytocin. And so it makes them very alert in that first hour of life. It's helping them to learn. So they're intentionally very alert at that time. Newborn babies otherwise are quite sleepy often. So they'll wake, feed, we go back to sleep again. But in this time, they're really awake, and it's on purpose so that they can learn. They can use those innate reflexes to crawl to the breast, and then they can latch on and they come off, and they latch on and they come off. And sometimes they get a bit annoyed about the fact that the milk's not coming in really easy, because they're used to not having to do anything for a meal. They've been in you, cozy, kept nice and warm by the amniotic fluid, which is a degree above your body temperature. So they're like cozy in this nice bath. They're getting fed directly into their blood system, so they've never had a gurgly stomach. They've never had to digest anything. They've never had to do all this sucking and working for their food. This is like hard work. So they might be a bit cross about it and tell you, but you just reassure them, going, This is life, my friend.
Mate.
Feeding is a joy of life. Actually, you'll soon learn to love it, and you'll know if you have toddlers, or when you get toddlers, they are boob obsessed. Because boobs are the best. They're awesome, and so they're learning. And you just reassure them if they're getting a bit frustrated. You just talk to them, go, "It's okay, darling. You're learning. We're all learning." And that just calming voice helps reassure them.
It's so wonderful for them.
They understand far more than we realise in terms of language. They really do. They might not be able to communicate back in the same way, because forming language is actually quite a complex process, and that's why it takes time. But I know babies from quite young ages, like a couple of months, really understand if you say, do you want some milk? And, I did baby signing, and I try to encourage people to learn sign language with their babies, because it really helps in those years of frustration where you're coming up 1, 2, 3, where communication is just starting, but it's not quite there, and it's difficult for them to get you to understand them, that they get so excited when you understand what they're trying to say. I just remember the joy on Seb's face when he was trying to explain things to me, and he would do it with sign, and I would go, oh yes. Like, he learned that. I've got this lovely video of him like doing the sign for baby, and he was looking in a magazine, and he'd seen a mum and baby, and he was pointing at the page and like doing this little rocking, and I'm like, that's right, yes, a mum and a baby. And he just was so happy that I had understood what he was trying to say. Yeah, it just helps reduce the stress of tantrums. And even with tiny babies at a couple of months, if you are always signing milk, so the sign for milk is like a squeezing of your hand. Those of you watching on the video can see it, but you kind of have a fist and you squeeze and open your hand for milk, and babies will sign that in a couple of months, up to around about 4, 5, 6 months, they will sign it. And even if they can't sign back, you know, if you sign it to them, you will see their eyes will light up and be, you know, they'll be wanting to do it. So having this communication with them, explaining to them what's going to happen, is so helpful. And for me, it's especially important, I think, in helping to understand about consent as well from a really young age. So saying to your baby, you know, we need to change your nappy. So you do the sign for nappy change, which I think is something like this. I'm just testing my signing knowledge I'm remembering now. You can make up your own signs. Actually, Seb, when he was little, was really cute, started to make up his own signs for things. And he did this lovely sign for a hot water bottle, if you wanted a hot water bottle, where he'd wave his hand side to side, and he'd also go, lottle, 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 lottle. That was his sign. It was so cute. So yeah, I highly recommend that. But you know, in those first few moments, obviously the communication is more about just watching what your baby wants, watching their movements, and reassuring them when they're going to feed. And this, if babies have this undisturbed latch, so this is something that is so vitally important for me as a doula. I'm really protecting your space at a birth. So I tend to get the partner on one side of the person who's birthed and me on the other, and we are literally forming a protective ring around you, so that you don't get people whose job is time sensitive, where they're trying to rush these things because they've got to tick boxes and move on. Because so many times I've seen probably a well-meaning midwife, but maybe who doesn't understand how important physiology is and this learning of the initial latch of breastfeeding, who will come and just shove a babe onto a boob. So I stop. I just stand in the way of that.
I do love you guys that are so understanding, but it's your only job is to understand the physiology of childbirth. I don't know how we can put well-meaning and ignorant about childbirth in the same sentence. No.
Okay, fair enough.
It's not good enough. Okay, learn it.
You can listen to us and we'll teach you all about it. That's what we're here for.
Unless you're an obstetric nurse. If you're an obstetric nurse, then yeah, of course, obstetrics doesn't give a fuck. But if you're a midwife, please don't show up for work if you don't understand all of this. Just don't bother. Go and do something else.
Yeah, I mean, it's why I sort of say to all of my clients, don't invite people into your birth space unless you feel you need them there. Because you don't know who's coming in, you don't know their knowledge level and their understanding, and the less people you have in a space, the less likely problems are going to happen. If you feel like there's a problem happening, if you feel like something's not right, that's the time to invite someone in. But if there's nobody there, there's no one there to pull on your cord, to shove your baby into your boob and make them averse to breastfeeding then, because you know they've had food shoved in their face and it's frightening. You know, you've not got people go, you might be doing this wrong, you might be doing that wrong, that's affecting your confidence, when you're just instinctively holding your baby close to you and looking after them. That's, you're not going to do dangerous things to your baby if you're in an instinctive state. You really aren't. And it can feel very jarring to have people start talking in that time. It's because you're like so connected with your baby. And I remember watching a video, someone was studying the breast crawl and that interaction, and she says looking back now she just feels absolutely mortified that she was filming this beautiful oxytocin bonding of a mother and baby, and they were completely absorbed looking at one another and just falling in love. And she asked a question and she broke the spell, and looking on the video she can see that spell broken. and the time it took for that bonding to come back again. And I can't remember who it was, but I just remember her saying, I just feel so awful that I did that.
Yeah.
You know, I was like caught up in the moment, how lovely it was.
Yeah.
You know, so there shouldn't be. Did you want vitamin K? Should we cut the cord now? So what are you doing about bed sharing? Like, we don't need any of that in this plan. None of that. I've had leaflets being shoved at clients. This is about safe bed sharing. I'm like, now is not the time for leaflets. Just put them quietly on the side.
Chill?
Let's zip it.
Zip it. Zip it. It's my favourite phrase if I'm with people that are breaking the spell, because it's disrespectful and it's ignorant, and it's something that we all, those of us that work around mothers and babies, need to be aware of, because it is sacred. And it's a one-time only deal. And once a spell is broken, it's broken at that point. Yes, of course, there may be other chances to reconnect them or to facilitate reconnection. But that first hour that Shelley's talking about, where the baby's purposely been woken up to share the gifts with the mother and their other parent in that first hour. If you're ruining it with stupid questions just to tick boxes, you've missed the point of your calling.
I try to say to parents, put on your birth plan, if you are choosing to birth with attendants, be that at home or in a hospital, make it really clear on your birth plan that you will tell them when you're ready to cut the cord. Excellent. So that you don't get, there's like this obsession. Should we cut the cord now? Should we cut the cord now? Should
Everyone
we cut the cord
just
now?
chill, just shut up. And I talk about the 3 hours now, the golden 3 hours, because I think whenever we talk about the golden hour, people that are disrespectful with badges and letters after their name will make that 15 minutes. So I think when you say it's the golden 3 hours, they'll hang on at least an hour, and that'll give you enough time for you and your baby to share all those benefits of the physiological stage beyond the expulsive stage, which is so important.
I think it's like anything with an arbitrary number is made up and not true.
Oh,
you know
for real.
Like an arbitrary, this amount of minutes or seconds to cut a cord. Someone's saying it's 30 seconds or a minute is enough.
Yeah. Where'd you get that from?
we all have different amounts of blood in our body. We all have different pulse rates. So exactly, what might be for one baby who needs a minute or 3 minutes, another baby might need 10 or 20 minutes, and if the physiology is disturbed, so I attended a free birth recently, and actually the baby came very quickly, so I wasn't there when the baby arrived, they were alone. And the dad panicked a bit and called an ambulance because there was a bit of blood, and he tried to get through to me, but the call wouldn't connect. I could see he was calling me, but we couldn't connect. So he just was like, oh, I'm not sure about this, and phoned help, which is what you should do, absolutely, if you're concerned. Then he phoned me and said, I think everything's fine, but I've got paramedics and everyone coming on the way. And I just said, okay, if she is well and everything's okay and there's no more bleeding and not concerned now, just do not let them disturb her. Keep them downstairs, very quiet. Don't want 4 people rushing in with all their bags and all the Velcro and all the like, hello, we've just come to see how you are, so just keep it really calm and quiet. And bless his heart, he did. He managed to keep everyone downstairs, didn't let anyone up to see her.
Well done him.
Which was just so brilliant. He did so brilliantly. And then when I arrived, two very annoyed midwives, because he was like, he'd said that the doula was coming, and he said to me as soon as I came in the door, she wants you upstairs. And they were like,
sour face.
So I was allowed up, and they weren't.
That's right, because they trusted you to not disturb the bubble.
Bless them.
It's just a respect thing.
Yeah, and to be fair, actually, the midwives were very respectful, and they popped in very quietly to check and, asked things, and then went back down again. So they were really, really brilliant. These last couple of births I've had, I've had some really good experiences with midwives, which is quite unusual for me.
That's really good. And I've heard a few good experiences this year. Obviously, it's not the majority, so I can't tell everyone to exhale yet, but definitely someone's listening, so it's good.
And with that birth, actually, we were feeling the cord pulsing. So it took probably I think it was an hour and a half, hour and 45 minutes before the placenta came. And, you know, of course, downstairs, the midwives are getting a bit twitchy because it's over an hour. And I'm like, of course it's over an hour, because you had a disturbed, you know, there was disturbance, there was phone calls, there was the knowledge that people were coming into a space, you know, it set back the physiological clock of things happening. So just stay calm, just stay feeding the baby. She was side-lying, the baby was feeding, side-lying the bed. I kept everything dark, kept the lights off, etc. And then when she started to feel the surges, then it was okay. She went squatted in the bathroom actually when the placenta came out. So, you know, this, like, it has to come after an hour. You need to go and have some horrible, like, manual removal after an hour. If actually you're okay, your uterus is feeling firm, you're not actively bleeding, it's not concerns, then it doesn't matter if it's a bit longer or even a bit more long. You know, there shouldn't be a time limit on these things. And I've supported people who have had manual placental removal, and they just say it's like hideous, it's brutally hideous after you've had a really nice birth. So, you know, I would advocate for doing some natural things like keeping the baby skin to skin, getting the baby feeding. Actually, I've got some research about how effective skin to skin and feeding is on that. I'm going to talk about in a little bit of time, to help. You know, there's natural things you can do to help get the people out of the room, give yourself some privacy. All the things that we're using to build oxytocin in birth, we can do again with the placenta. Make sure you've had a wee, because the bladder's in the way of the placenta coming out. You know, have a cough, change position, you know, all this stuff. You talk for a bit about placentas coming, and I'll try and find that bit of research.
I will. Thank you. The thing is, in actual fact, because I have been to quite a few hundred births, seeing the placenta outside of the woman's body within an hour is the minority of times. The majority of times they'll take between 75 and 90 minutes. I don't actually bring up the placenta at all. It will never be me. It will be the woman will suddenly notice that some kind of cramping or discomfort has come back. So she'll be probably between 10 and 20 minutes. I might not notice any kind of cramping or switching around. So she'll be totally falling in love and in her bubble, and then she'll start to notice, and then you might see a tiny little grimace, or she might have forgotten that there's something else that needs to be born. Because
the disappointment of realising there's still a placenta.
It's like,
horrible.
It's horrible. But
you're having all these lovely cuddles, and then you're like, oh no.
Something else. Exactly. So that's why I won't bring it up at all, and I don't disturb it unless I see excess blood loss, which hardly ever happens with psychophysiological birth stage. And I've maintained the environment. So even when the babies come, mother's exhilaration and her partner's exhilaration and noises, etc., will be very clear. But me as a midwife or a birth keeper, I don't have to say a single word, and I just wait for eye contacts, and then she kind of invites me with her eyes to admire her baby and what she's done, then I will. But because I don't mention it, often the woman won't mention till she's coming up to around 50 minutes. What is that? You know, she doesn't remember.
Yeah, I'm feeling something.
Yeah, exactly. And then I'll remind her that the birth isn't complete yet because the placenta is to come. So it's maintaining that environment is one of the things that I think has enabled me to see very little excess bleeding.
And then, me too.
Yeah. And then
I've never seen a hemorrhage in a physiological birth.
No, but because you work as a doula, sadly, you will have people that you're not familiar with that are, you know, calling themselves midwives, who will be disturbing the space. So and that's one of the reasons why I was an accountant before, but moonlighting as a doula. But I became dissatisfied with that because there were people coming into the space who claimed that they were midwives who were disturbing births. So in the end, I said, I better just pursue my midwifery career so I can stop having amateurs in the room causing problems. So, and that's literally what forced me into midwifery. But so around 50 minutes, she'll start thinking about it. Her legs might still be a bit wobbly or whatever, but she'll be thinking about how can I resolve this discomfort, this rhythmic discomfort. And that then she'll look at me again, and then I might suggest, well, would you like to squat where you are, or shall we get occasionally a bucket to sit on is not comfortable, but sometimes women need that because they might not want to go to where their toilet is.
Yeah.
But there'll be all sorts, or I'll just say hands and knees, keep your baby with you, or put baby in front of you so you can smell your baby with that beautiful wet head and all that yumminess, and then they'll be ready to let their placentas go. So I tend to see them out about 1.25 hours afterwards. So immediately this hour rule, it's like what you were saying earlier, Shelley, with these arbitrary numbers.
Yeah, and in America it's 30 minutes.
It's unbelievable. So of course you're going to see a lot of fucked up third stages because you're forcing the body to do something it's not ready to do. Whilst if you're able to be patient, not bring it up, not show people your watch and all this stupidness, you'll see it appear usually after the hour. But I know, people listening to this, again, will take it as a rule. It's not a rule. If the woman's expressing discomfort earlier or moving around earlier, assist her earlier because she's ready to let it go at 15 minutes or 5 minutes. I was also going to say about something I observed as well from births is if a baby has had a wonderful birth that has been timely and the baby appears outside of the body and barely cries and just seems to be very chill with the whole experience, that cord will pulsate for, well, we don't know because I try not to feel it, but just looking at it could be up to an hour, between 20 minutes and an hour. If you've got a well-perfused baby that just is alert and transition beautifully. Whilst if you have a baby that's had a bit of a challenge or a struggle, sometimes you'll notice that their cord goes white in about 3 minutes because it's, and so all I can surmise at the moment, and based on physiology as well, is that baby has required their third back from the placenta quicker, possibly because of the challenges of the birth.
Do you think if their heart rate is high because they're stressed, that's going to drive, their increased heart rate's going to drive the blood from the placenta into the baby much quicker, whereas if they're more chilled out, it would be a slower transition.
But I also feel it's about the vasoconstriction or vasodilation of their own blood vessels inside of the umbilical cord. I think that plays a part in it as well. It's not necessarily particularly even just their heart rate. It's just speaking to the intelligence, the innate intelligence of birth, that you can see these differences when you've seen a number of births. So it's just like there's no one size fits all. It's just being able to observe is one of the key things. Being quiet, less is more, and observe.
I heard a wonderful story from an amazing midwife, Nauli Veneva. She's a Mexican midwife, traditional Mexican midwife. She's an absolute joy. If you can do training with her, I highly recommend it. She's such a character. And she told this amazing story once of a baby being born, and her tendency is to leave the placenta alone, much like you and I do. Don't talk about it. Just leave the family to get to know one another, just sitting quietly in the corner, watching to make sure everybody's okay. Just being responsive if asked questions, but otherwise zipping it. Just being in reverence at the joy of everything that's happening. And she would just put the placenta in a bowl when it was birthed so that the baby could do breast crawl and feed and leave till well after a feed. Because if a baby is well perfused and they're breathing well, they will feed effectively. if they're struggling with their breathing, they're not going to be interested in feeding, because they're trying to get oxygen into their body. When you're stressed, stuffing your face is not your priority in acute stress. And it's exactly the same in babies. If they are compromised, they are not going to be interested in feeding. They're not able to cope with it yet. But when they do, it's fine. And she had noticed with this particular baby, the baby was feeding, everything was fine, really good. They'd felt the cord and it had stopped pulsing. But their family were like, well, yes, just have a little bit more cuddle, we'll wait to cut it. And then momentarily, the baby started going, like making a like weird noise, that's struggling for breath. And she had felt the cord and it had stopped pulsing, and she instinctively felt the cord again and it had started pulsing again.
Oh, my
baby struggling with the breathing. And that was 45-50 minutes after the birth. So they'd seen a stop and then it had gone again. Now, obviously, the placenta is not attached to the maternal body, so you're not getting that translation of oxygenation from the mother's blood, but there's potentially still a bit of blood left in that cord.
There might be oxygenated blood in there, of course.
Yeah, so the body was like, and it was very sweet, because she told the story that the next day, the dad, everything was fine. After a few seconds, the baby just sort of did a big gulp and then was fine. And then the next day, when she went to visit them to check on them, the dad was like, Nowly, I know what happened. I know what happened with the baby. Come see. And very excitedly showed her the nappy, that a bit of membrane had obviously gone into the baby's mouth and it had come out through the nappy. The membrane had come out through the poo. And so they think that the membrane had very momentarily just covered, and then the baby had swallowed and it had gone past. And that's why there had been that momentary instant.
Fascinating.
But that the placenta had, gone, to help the oxygenation, just makes me think, what's the rush? Just leave it attached. Baby can have a feed. It can sit in a bowl. If you don't want to look at it, cover it with a muslin so you don't have to look at it. And also, people are less likely to come and bother you if you've got a placenta in a bowl next to you. It's just another deterrent to interruption into your space.
Beautiful deterrent. And you see, that speaks to, again, the less is more approach, which many of us that are confident and work more traditionally, we wouldn't even dream of cutting and clamping a cord till about 2 or 3 hours after the baby's born. We just don't do it. It's and just like what you're talking about, the baby had a minor obstruction. The placenta the baby demanded whatever was left of the oxygenated blood in their placenta, pulled it over to compensate. If the placenta had already been removed, cut and clamped away, it wouldn't have been available for that.
Pretty amazing, huh? So I found the thing about so there was an investigation by Chua et al. On breastfeeding and uterine tone. So the findings revealed that there's a 17 to 73% increase in uterine activity with breastfeeding and nipple stimulation when compared with averages found pre and post intervention. So that's with synthetic oxytocin or not. So all subjects demonstrated increases in their uterine activity, with a major increase among women who had breastfed their babies compared to women who were manually stimulating their nipples. So, if there is excessive bleeding or something happening, something that you can do naturally is to get the breast stimulated. So that can be with the baby, or if you've got an older baby, a toddler that's still nursing, if the baby's not interested, they can come nurse. And then, if that's not working, then you can do the nipple stimulation if you want to. And what this study pointed out was that median increase in uterine activity with breastfeeding was around 93%. And when they compared that to the increase in uterine activity with synthetic oxytocin to prevent PPH, that was 96.5%. So they said in the study that it's comparable amount of uterine activity. And with breastfeeding your baby, you don't get the side effects that you get with synthetic oxytocin. So when you are having synthetic oxytocin, in a study by Begley et al., they found that there was a significant increase in maternal diastolic blood pressure. So by having synthetic oxytocin, it significantly increases your blood pressure. Vomiting after birth, increased after birth pains, an increase in use of analgesia from birth to discharge from the labour ward, more women returning to the hospital with bleeding, and they also showed a decrease in the baby's birth weight, which was related to them jabbing and cutting the cord quickly, so the baby didn't get their full complement of blood. So that loss of weight was from the loss of volume of blood going into the baby.
So was that just syntocinon, or was it also synthometrin?
Because with the vomiting and headache, that's
and
often
the blood
synthometrin,
pressure,
isn't it? Yeah.
Potentially. A few people use them interchangeably, but synthometrin is a different preparation from syntocinon.
Yeah, so I think it's saying Pitocin here, which is interesting. So
right. So that Pitocin,
that's synthetic oxytocin.
That synthetic is the same. I don't think there's an ergometrin element to Pitocin. Interesting.
Yeah. What I found really funny was some of these other studies that said introducing skin-to-skin contact in immediate breastfeeding to prevent postpartum hemorrhage are considered innovative and crucial ways for the optimal.
Oh, I've got a great idea. Cuddle and feed your baby. Come on.
Look at this new innovation that we as scientists have come up with. Not that it's been the natural course of action for the rest of history.
Oh, there's such usurpers. There's such a bunch of usurpers, man.
So when you've got skin-to-skin contact, what it's doing is stimulating the pituitary gland to release oxytocin. So we get elevated levels of the hormone in the blood then, and the uterus is the target organ for that to contract down. But your brain is also the target organ. It's changing how you feel about your baby, how much you fall in love with your baby.
100%.
And this other study, they said, this is a relatively new way of preventing prepuation.
Can they shut the fuck up? I can't with these people. I really can't. I mean, we've got the robot in China that that will carry babies for you, and I love that they always spin it as well, like, oh, so great for infertile couples and whatever, when we already know that, you know, infertility is largely being caused by environmental factors and, you know, what toxins the woman received in childhood and the quality of the sperm, etc. Right? But no, we'll just build a whole robot to fix infertility. But can you imagine? They'll say, "Oh, this is innovation. You know, we've got to get the robot to cuddle the baby and get the robot to feed the baby because of this bit of research that was done in 2025 or whatever." I think that we're being extraordinarily silly.
Yeah, it's mad, isn't it? There was another study by Dordevic, I hope I'm saying that right, that revealed that skin-to-skin group experienced fewer instances of severe uterus involution. So as we were saying about like pulling on the cord and uterus coming up. Less post-delivery anemia, as measured by hemoglobin values and the number of erythrocytes. Reduced bleeding. Reduced bleeding, yeah. Less sanitary napkin consumption, so obviously less bleeding. and a shorter hospital stay. Then another study by Moore and Anderson revealed that the skin-to-skin group had a higher rate of suckling competency during the first breastfeeding. So the baby being undisturbed skin to skin meant that they were better able to feed and learn how to do it. And they were able to effectively breastfeed sooner. Consequently, very early skin to skin contact enhances breastfeeding success within the first 2 hours postpartum.
Excellent.
So that's really interesting. Then there was a study by Saxon et al. And it was a database study which included 10,000 women who were analysed for incidences of postpartum hemorrhage. And the findings revealed statistically significant results showing that women who breastfed or experienced skin-to-skin were less likely to have postpartum hemorrhage, significantly less likely.
Beautiful.
So all of it's saying, don't mess with mums and babies, leave them close together, let them just get on with what they want to do. And actually, another study which is interesting, so again about the time. So often they go, let's give an injection for the placenta because it will make it quicker. So Karimi et al. Found that the group with skin-to-skin contact had a shorter duration of third stage of labour compared to the control group, with a mean difference of 1.33 minutes. So just by cuddling up with your baby, it actually makes it quicker, not with being jabbed in the thigh, having all of the side effects that we've spoken about. So actually it does just make it better to leave you in peace having a cuddle with your newborn without all of the nonsense. And what was the other thing? Oh yes, Sabati in 2019 found that the breastfed group experienced significantly less blood loss, less by 194 millilitres, if you're interested, than the control group, and said that both skin to skin contact and breastfeeding have an influence on the amount of blood loss and the duration of the third stage of labour. So
How wonderful.
basically, leave people the F alone to just snuggle up and cuddle up with their babies. And in that time, the baby's on your chest, they're being warmed, their thermoregulation is sorted, they are getting good microbiome by picking up from your skin and your touch and not anybody else's.
And their breathing is normalised, their respiratory system.
Yeah, and their nervous system and your nervous system are normalised and not stressed. Now, when babies are taken away from your body, taken over to the other side of the room to be measured and checked and jabbed and all this kind of thing, it really increases their stress response, and it increases your stress response as well.
That's right.
Which is not great. You know, you don't want your first experiences of life to be stressful and scary. You want them to be calm and filled with love. So if at all possible, it should happen. And this probably comes onto a massive bugbear of mine, you know, something that really, really makes me cross about hospitals, that they are not prioritising keeping mothers and babies together and cords attached, because there's so much good quality evidence showing that leaving a cord attached leads to better outcomes. It prevents lots of deaths. There's quite a significant number of deaths which are directly associated with early clamping and cutting of cords.
Yeah.
You know, when a baby is in poor condition, it's even more important for them to get that oxygenated blood from the placenta. So why is this not a priority in hospitals? There are people who have invented trolleys that mean that they can have a flat surface. If a baby, you know, sometimes if a baby needs help breathing, they might need to be on a flat surface to be able to tilt their head back to get more oxygen in. Maybe even if compressions are needed, if a baby's in a really, you know, really poor state, it's difficult to do on a mother. You know, with getting inflating lungs and things like that, it can be done on a mum, just helping to, you know, give them that little help with the lung expansion if it's needed. But it's not prioritised.
No.
And it's causing death. It's causing death. And I'm just like, why can't we have this equipment that comes to the mother? Why do we have it the other side of the room? I was at a birth, and the paediatrician had got called in because, you know, the mum was over 42 weeks, and, you know, they thought that everything was going to be disastrous. This baby came out, was shouting, wriggling around, like great tone, great colour. And the midwife's going to come and cut the cord. And I specifically stated before, the mother does not want the cord clamped and cut. The paediatrician was stood across the other side of the room on the resuscitator playing Candy Crush Saga on his phone.
Wow.
And she's like, then she started milking the cord, because she was like, it's the same. If I milk the cord, it's the same as leaving it. We need the paediatrician to check the baby. I was like, the paediatrician can take, so I'm getting all shouty, can take the 2 steps across the fucking room to look at and assess this baby. I can see this baby's fine. The baby's got good tone. Is crying. It's a good colour. There's nothing wrong with this baby. That you don't need to clamp and cut the cord. They did it anyway, against her wishes.
Wow.
Took the baby across the room.
Wow. So you see, but I don't even. I can feel the tension, and it's there because, honestly, when I'm listening to birth stories, the 2 things I ask more than anything are, was the baby born vaginally? Because then I know the baby would have had the microbiome from the mother. Now, that doesn't mean it's an optimal microbiome. It depends on the mother's microbiome. If she's been having antibiotics, or if she's had Hibiclens, like an antibacterial ointment all in her vagina, that's going to upset the baby's microbiome. But the biggest thing that is irreversible is the baby's full blood complement. So, you know, when somebody is looking to clamp and cut the cord, you've got to be able to ask yourself, if you're there to support, am I here to make friends with this obstetric nurse, or am I here to protect the well-being of the mother and the baby? And if you know what you're there for, you will do what Shellie did, which is fight to keep that baby's blood we're going to talk about blood complements in a minute, but to keep that baby in the situation where they will have access to their full blood complement. So thankfully, the vast majority of the time I'm at home with births. My transfer rate was around 5%. So I was vast majority of the time I saw babies born at home. But if I was in the unit, I was prepared to throw my body across the cord to prevent the cord being clamped and cut. But on the other hand, because I was on the register, I was often challenged on this kind of behaviour, but I could defend it and I could show the receipts to back it. And so I was never disciplined for acting like that. Of course, I was hated for acting like that, but I did what I was supposed to do, which is protect the woman and her baby and the baby's well-being ongoing. So without trying to over egg it in any way, I have to tell you that if you're giving birth, have a plan for how your baby's going to get their full blood complement, especially if they're compromised.
And make sure you've got somebody in the room who is able to advocate for that for you. And like Kemi said, actually physically step in if needed, because you are high on endorphins, oxytocin, you're shocked by birth, you're amazed by birth, you're in that altered state, and you are not capable in those moments so easily of advocating for yourself to stop it happening. So having support people there to help is vitally important. And I would say, even when you have experienced advocates with you, like myself, I've been a medical advocate for a very long time, we're still trampled over and ignored sometimes by medical professionals. It does
absolutely
happen. The eye roll of that we don't know what they're talking about and they just want to do what they want to do. So I think it's really important to put in your birth plan, make sure your birth plan is read, make sure it is understood. Somebody reiterates before birth, do not clamp and cut the cord. I do not consent to it, that it's coming from you or your partner, because they will listen more than coming from a doula.
Yes.
They just roll their eyes at doulas. They think that we're trying to put our thoughts in the birth space, that we are forcing you to do what we want you to do, because that's what medical professionals do to you. They coerce you until you agree to what they want. That's how they're trained. They're trained to get you to follow the path that they want.
Way. Yeah.
So that's what they assume that I would do as a doula, that I've bullied you into going, don't let them cut your cord, keep your placenta attached and then eat it, and in under the moon whilst wiping the blood across your face. That's what they think is happening. What I'm there to do is facilitate what you have learned feels right for you.
Exactly.
Be that either you want to have vampires take your baby's blood from the cord, be that you want it immediately cut, be that you want to wait and do the thing I just said in the moonlight, or be that you want to just bury your placenta under a tree and just keep it attached for an hour or however many non-arbitrary time until you feel ready to cut it. Maybe you want to do a bit of a ceremony to thank it, to speak to your baby, to ask if it's okay for that separation. And if I'm helping couples alone without medical professionals, I will always do that. If they're wanting me to show them how to do things safely, I will always say, just ask your baby, are you ready to let go of your placenta now? Because sometimes they don't really want to.
No.
And then you instinctively think, okay, I want to wait a bit longer. So jumped in there with a thing.
I love
should we talk a bit about blood?
Yes,
let's talk a bit about blood. Let's go vampire-y. Let's go all Buffy. Actually, Buffy the Vampire Slayer. That's where we're at. Slay the vampires. Keep the blood for yourself.
Honestly, keep the blood for your baby.
So I'm going to start with parental blood volume, actually, because I think that's quite interesting. And I've got some props. Those of you on the video are going to be laughing at me trying to hold all of these up. Should have done my weights, should have got my biceps ready. So in a non-pregnant person, so blood volume is dependent on how much you weigh, how big a person you are. So it is variable, but around on average, most people have about most women have about 4 to 4.5 litres of blood. So those of you watching on the video can see me holding up 2 bottles of 2 litre bottles of blood here. Now, in pregnancy, in sort of early to mid pregnancy, your blood volume increases by about 30 to 50%. Okay, so I've got another litre bottle here and another 2 litre bottle here. So you've got all of this. I'm going to try and lift it up for the camera. All of this blood in
Very
the body.
good.
Okay? And that is to help. You need this extra blood to help with perfusing the uterus, for helping with placental things. And it's also there because your body naturally knows that you might lose a bit of blood at birth, and if you've got a bit extra, then it's okay. And actually the blood is more dilute in pregnancy, and that helps to prevent clotting, because obviously with blood going through the placenta, we have an increased risk of, or chance of, clotting in pregnancy because of the changes happening in the blood, and so it helps prevent that. You've got more plasma content. So kind of average blood loss for a vaginal birth is about half of one of these bottles, so about 500 mils. So we've still got all those other bottles. I wish I could hold them all up at the same time to show you, but they're all here.
Yeah.
I've got 3 more big bottles. Yeah, so about this much. Or if you have a cesarean, it's normal to lose about this much.
Yeah.
So a litre of blood. And as Kemi so beautifully said in a previous podcast, I think it might have been 2 podcasts ago, we were talking about the progesterone changes throughout pregnancy, and then we get this change after birth as well. So the changes in the hormones are changing how the blood vessels are doing. The relaxin helps to dilate the blood vessels, so it's easy to get to the uterus, so it's easy to get to the breast to help build up the milk production stuff going on. That was a very technical term there.
Stuff.
Milk production stuff. Helping with lactogenesis is the proper technical term. So we get this, we might get a very slight increase in blood pressure towards the end of pregnancy as that relative progesterone level drops. That's very normal. More of an increase in blood pressure is not so normal. Yeah, if we're getting a more significant increase and we're getting other symptoms, then it's, worth looking at to make sure what's going on. But we can help to prevent that by eating a really good diet. Yeah. And what am I going to say now? Yeah, so after birth, with this change in hormones, so we're getting the drops and changes and things like that. And I won't go into too much detail of it now because it's kind of a bit boring to listen to. But if you are a birth nerd like us and are really interested, join us over on Patreon. I've got an amazing handout with just loads of information. So here, this is the black and white version. It's all in colour online. You've got a graph of what happens with blood loss and progesterone levels and other hormone levels and things like that, if you're interested in what happens. But basically after birth, you wee a lot more and you sweat a lot more, which helps to bring your blood volume back down to normal in around about 4 to 8 weeks. Yeah, so your blood pressure can be a little bit funky for a while after birth. So now we've seen how much blood is in a pregnant person. So normal adult, this much. Pregnant person, this much. Okay, let's talk about different types of hemorrhage in an adult. Okay, so if we lost 1 to 15% of blood, so about 750 ml, so if we kind of lost about this much of the bottle, that's considered a class 1 hemorrhage. Okay, so usually people would feel okay with that. If you go to give blood, you give about 500 ml. Some people might feel a bit faint, some people might feel a bit okay. And here we go with not focusing on arbitrary numbers again.
There we
because
go.
For some people, a small loss is going to really affect them and make them feel very unwell.
That's right. And that's why people, I have to jump in there, because this is very, I remember when I was studying midwifery, you could find online that the definition of a hemorrhage would be 500 mils or less if the woman's symptomatic. So if the woman lost a wine glass, like 250 mils, but she was looking pale or yellow or, in any way looked like she was compromised, that she's having a hemorrhage. And that's the true definition of hemorrhage. Whilst, I was trying to look for a class I was teaching the other day, and everyone has now revised that to just the figure, this arbitrary figure, 500 mils, or more. and the woman's sitting there perky as hell. And that the reason why this is a problem is because you have choices taken away from women, or transfers being done because of this estimate for an arbitrary number, when she could be in theatre losing a litre or 950 mils and no one will call it a hemorrhage, even though she's symptomatic.
Yeah.
So
it's not a hemorrhage if it looks bad on the hospital, but it is a hemorrhage if it means that you can restrict a woman's birth choices for the next birth.
There you go. Yeah, I don't want to say
because, but it needs to be said, doesn't it? Because the thing is, if you have a hemorrhage in one birth, it does not necessarily mean you're going to have a hemorrhage in another birth. They're not linked. And as you've heard from what we're talking about, usually it is interventions that cause hemorrhages. Okay, so very rarely you might have an issue with some retained placenta that's happened naturally out of nobody's fault. Okay, but most of the time it's because there's been interruption or intervention. Sometimes you might have a blood clotting issue that you know of. Okay, so then you know that maybe it might be more likely to happen for you. But most hemorrhages are caused by iatrogenic involvement, by drugs that are pinned to you, by things that are done to you. So if you have a very intervention heavy first birth and a massive hemorrhage, it's the intervention's fault. You know, that doesn't mean that you can't have a home birth next time and stay away from all of that nonsense, and you're most likely not going to have a hemorrhage. So that's really important. And it's interesting that these classes of hemorrhage, so for non-pregnant people, that's the 750 mil. Yet for a pregnant person, your class is a hemorrhage at 500. And like we're saying, you might feel fine, you might not, but that then restricts your choices. It's a bit like, well, you've got more blood when you're pregnant, so
that's right.
Most people can probably lose more and be okay. So then we go on to a class 2, which is 750 to 1500. So about this bottle and maybe a little bit more of another one. And in that case, people might have tachycardia. So that's a fast heart rate, fast pulse. They might feel a bit anxious, get a kind of anxiety feeling, and they might start looking a bit pale. Okay. Class 3 is around 30 to 40% of blood volume. So that's where we're losing like 1500 mil to 2 litres. So maybe a bottle like this. Okay, we'll bring this one back up. So now we've got this much blood in the system. Okay, and then you might start getting hypertension. So that's a drop in your blood pressure. And you might start feeling a bit confused.
Did you say hypotension?
Hypo, low, yeah. And then the class 4 is where you lose greater than 40%. So now the reason why I'm talking about these numbers is because we're going to compare it to what happens in babies when people clamp cords in a minute. So that's why I'm kind of emphasizing these figures. So around 40% is where we lose to 2000. Yeah. And that's severe. Okay. It's potentially life-threatening. You might get organs shutting down, and they're probably going to be wanting to transfuse you. Yeah. So, yes. Now in babies, at term babies, they have around 300 mils of blood. This is exactly 300 mils of blood here. Okay. So if your baby is slightly premature, they might have a little bit less blood. But if they immediately clamp the cord, because the placenta is a big organ, okay, the baby, 50% of the baby's blood may be in the placenta if they immediately clamp the cord. And what were we just speaking about? Above 40% blood loss is a major hemorrhage, like your life is threatened by that happening. And here we are, we're immediately clamping and cutting a baby's cord. We are putting them in a life-threatening situation by doing that. That's why I'm so mad about them not keeping cords attached and resuscitating babies.
I was only aware that there was 30% in the placenta.
So that's at term babies. Yeah, yes. So if a baby's premature, it can be up to 50.
Right.
At term babies, it's around about a third. So around about this amount in so from here to here is in the placenta and the rest is in the baby. But you can see it's still a lot of blood compared to how much blood there is, if that
Oh,
makes
it's
sense.
huge,
Yeah.
because when we give blood, we're only giving 500 mils, which is an eighth of our blood volume, right? 500 mils.
Yep.
When we're not pregnant.
Yeah.
So we give 500 mils, but we're not expected to just wander off and have a happy time. We're given some kind of sustenance and asked to rest for a little while.
Yeah, juice and a biscuit and put your feet up and
yeah.
Yeah.
Whilst our babies are expected to go without a whole third when they've got to learn to breathe using their lungs for the first time. So there needs to be perfusion to their lungs. There needs to be perfusion to their livers, because they've got to now process their own waste rather than shunt it via their mothers. And they've got this brain that they need to nourish. They've got to keep warm. They've got to suck their own food. But we're going to take away a third of their blood volume.
And leave them feeling rubbish. So we know that 30%, that can lead to, in adults, tachycardia, anxiety, not looking good. And in some people, they might have low blood pressure and confusion. And that's just do that to babies, because, and babies can lose, if you take 30% of their blood volume away, that is this amount of weight.
Yes.
About 200, I put these on the scales earlier, 214 grams of blood not in the baby. Like about an average apple or a couple of avocados.
Wow.
So it's quite a significant amount. And like Kemi was saying, they need that extra blood to help their lungs expand and work properly, to help their liver and kidneys start working properly, because they haven't been doing things so much in the uterus, because the maternal blood system has been doing that, and then it recirculating through the placenta. So parts of the baby that weren't really functioning in the same way before have to transition over. And so taking that blood away really affects that transition. It affects the function of the baby's major organs. It really affects the function of the baby's brain.
Can I have a look at weights again? Because I'm such a nerd. So 300 mils is the baby's normal blood volume. When we mishandle the blood complement of a term baby, that's 100 mils that could be missing from the baby. So that would be one avocado, not two, right?
So it's I weighed these avocados. They're a bit old, so they've probably gone a bit wrinkly, but these weigh 214 grams. So they're up together, so up to 214 grams.
But if
weight. So it's about an apple.
But if the baby's got 300 grams stroke 300 mils, it's the same thing, right?
Yeah.
So that would mean that the baby has had removed from them 100 grams.
This was a study by Farah et al. In 2011. They found that the baby gains up to 214 grams of weight in the first 5 minutes with the cord intact and unclamped.
Interesting. Okay, so, I've got to look at that bit of research.
So yes, because exactly, like you say, if they've got 300 mil and then there's 214 grams, that means that it would be 2/3. It would be the other way around, wouldn't it? So that's an interesting point. I mean, the blood is important for a number of reasons. So initially, in that transition period of helping the heart to work, helping the hole in the heart to close up and the perfusion to go round into the lungs where it hasn't really been bothering before because it's not been needed, that it's going to the kidneys, to the liver, to the brain. And the blood itself contains stem cells. So Kemi talked about this beautifully in the last episode about how, the baby is being squeezed, their brain is being compressed as they're coming through. There are micro traumas to the body. Babies often have bruising from birth, from being squeezed, like pushed against hard bits of pelvis and that kind of thing. And so all the stem cells and the iron and everything are needed to help heal those problems.
100%.
And if the baby hasn't got that blood complement, they're not able to heal as well. If you are in an emergency situation, you've got mass casualty thing happening, and you've got someone who is unwell and not bleeding, and you've got someone who is unwell and bleeding, the paramedics are always going to prioritize the person with the blood loss because they're the person that is in more danger of an issue happening. 100%. Babies are tiny humans. Yeah, they're not aliens. They need the same things as we need, and it's arguably more important for them than for us because they've got less reserves.
100%.
So we just need to prioritize their health. And poor iron stores in the first year of life are known to harm the developing brain. So we have research showing that clamping a cord early harms your baby's brain. It harms the brain development. It harms the myelination. So that's like the coating of the nerve cells so that you get good communication throughout the body. The nervous system's working well. And it's been associated with a range of developmental disorders, including dyslexia and autism. And there's a persistence of poorer cognitive, motor, affective and sensory system functioning in children who are anemic as infants, so who have had their reduced blood volume. And delayed cord clamping is an important factor in contributing to health, and it was
but it's a compromise.
So.
It's a compromise. We know it's got to be optimal cord care, because if we call it delayed cord clamping and they perceive that they're keeping the cord intact for 3 minutes, that it's been measured, it's been tested, and they're actually keeping it intact for 90 seconds, which falls far short. So we know it's got to be optimal cord care, or at least 5 minutes. Optimal cord care being wait for white, like stops pulsating.
Wait till it stops pulsing. I think really time limits are just a ridiculous idea.
I
because
agree.
I there was an obstetrician at a birth I was at recently. He said, well, optimal cord clamping is 3 minutes. That's what we do here.
No.
And it's not. It's when the cord has gone white and it has stopped pulsing, and you feel it yourself and you say, I consent to you cutting the cord. Before that, nobody should be touching it. Nobody should be talking to you about it. End of.
100%.
It's recommended in research to leave it. And the thing is, there are these arbitrary time limits because there have been studies. And so they're like, oh, let's study what happens when we clamp it at 30 seconds. Let's study what happens. And do you know why that happened? I mean, I know you do, Kemi, but people at home may not know. So, like, immediate cord clamping began in the early 20th century.
There we
and
go.
Why did it begin then? So before that, cords were just left. And, probably when people thought about it, much like happens when we're sporting physiological birth, when someone's like, oh, should we cut the cord now? Yeah, it's been ages. We had loads of cuddles, baby's fed. It's all white and floppy and it doesn't seem to be doing anything anymore. Okay, it's sort of getting annoying carrying around a placenta in a bowl if you're moving anywhere, whatever. But it happened because, as Kemi said in the very first episode about how she was born, with the twilight sleep, her mummy drugged up to the eyeballs and, yanked out and things. So they were filling mothers with so many drugs to knock them as unconscious as possible. And you're still not completely unconscious and thrashing around. I mean, it's just hideous time of obstetrics, really. Are they all hideous? Maybe they are. All the times of obstetrics. So they were killing babies by overdosing them with drugs. Okay, babies' livers are very small. They're not as effective as adults. So what may take us, if we have an epidural, for example, a number of hours to clear the medications from our system through the processes through our liver, for a baby it may take days or longer. So they have drugs in their system for a significantly longer period of time, which affects how they latch, how they breathe, how they interact with the world, how they are alert or not to learn how to breastfeed at that time when they're supposed to be learning it, all that kind of thing. And with this twilight sleeping and drugging, babies were dying from not breathing because the opiate medication suppressed their respiratory system. And so they were like, oh shit, the babies are dying. Let's clamp the cords. Let's clamp the cords. Stop all the drugs going into the baby, and then they'll be fine.
Stop their blood going.
Yeah.
You've heard us nerd out. The story continues.
Oh yeah, we've got to stop. We've got to go. We've got mamas on the line waiting for us.
We have got mamas on the line.
To be continued next episode, everybody. Sorry for the abrupt finish. Lots of love. See you soon.
Lots of love.
Bye.
Bye.
Remember, you can join us over on Patreon for extra resources with every episode and a growing community of physiological birth rebels. This is the revolution, and you're all invited. The information shared in this podcast is for educational and informational purposes only and should not be construed as medical advice. The views and opinions expressed by guests are their own and may not reflect those of the hosts. This content does not replace professional medical guidance.
you.